Good morning.
Good morning.
Remember, I'm taking notes.
Good morning, Dave. Good morning, everyone. My name is Alex Kosmidis. I'm a glaucoma specialist, general and comprehensive ophthalmologist. Welcome, good morning, on this sunny Saturday. Welcome to the Cleveland Eye Clinic. This is our relatively brand new Avon Point office. Again, this is the Cleveland Eye Clinic. And welcome this morning. I wanted to give a talk, some basics about glaucoma and current available treatments. Before I begin, I would like to thank those who helped put this on, including Miss Michelle, Kathy, Phil Sultan, and also I would like to thank my colleague Selena Morrison, whose skill and dedication to my patients has really made my practice thrive and grow, and very pleased to be back here on the west side of Cleveland, where I grew up. So very much thank you. Thank you all for being here. So briefly, I'd like to explain some of my educational background. I did grow up on the west side in North Olmsted, Ohio. I was a graduate of North Olmsted High School in class of '99. I did obtain a degree in music, piano performance at the Cleveland Institute of Music, as well as a degree in biochemistry at Case Western Reserve in 2003. Followed with a medical degree from Case School of Medicine in 2007. And as you know, in medicine, there's much training beyond just medical school. I did an internship, transitional internship at Riverside Methodist Hospital in Columbus, Ohio, a year later, and returned to Cleveland to complete ophthalmology residency here in Cleveland with UH system, including UH, the Veterans VA Administration downtown Cleveland, Metro Health, and St. Vincent's. Following my residency, I completed glaucoma fellowship at LSU in Ochsner Clinic system in New Orleans, Louisiana, after which I spent a number of years thereafter working in Southeast Louisiana in different forms, both as faculty at LSU as well as in private practice. So very pleased to have you all here this morning. Thank you. To begin, excuse me. This is a brief courtesy announcement from the National Institutes of Health, NIH, the National Eye Institute. A brief summary of what glaucoma is about before I go on to my own talk. This is readily available from your tax dollars. A brief discussion of glaucoma. What glaucoma is, how it affects the vision, how important it is to detect it early on to find concerning signs, and a bit about the examination. Glaucoma is a group of eye diseases that can damage and atrophy the optic nerve. There are a variety of forms, but the bulk, the vast majority in the world are of the primary open angle variety, primary open angle glaucoma. We'll discuss briefly some other more common forms that do arise in our clinic. The problem with glaucoma is it can permanently reduce or snuff out the vision, and typically it happens. Vision loss in glaucoma begins in the periphery, the far periphery of vision, can cause permanent blindness if not treated. Next, you'll see here a cartoon of an eyeball cut in half. And you may or may not be able to see my cursor move, if you can see that. The theory behind glaucoma is a buildup of pressure, the fluid or aqueous inside of the eye. The theory goes that the drainage system within the eye, also known as the trabecular meshwork or angle, the theory goes that in glaucoma, this drainage system gets clogged up. It no longer supports an outflow of the fluid in the eye. As the drainage gets clogged up, the pressure in the eye builds. It builds throughout the eyeball, but most importantly, it can slowly push on and atrophy the optic nerve, what connects our eyeballs to the brain. Left untreated, this high eye pressure, whether over months or many, many years, can lead to slowly progressive vision loss. Again, beginning in the periphery and in its end stages, leading to entire snuffing out of the vision. An example again of the sink. The normal sink, water flows through the drain, flows out, and there's no problem. But in a clogged sink, there's something happening within this drainage system. Pressure and fluid builds up, and this is where things can go awry for the patient. Glaucoma is very common, especially in the United States, but even worldwide. Now, there's about 340 million people in the United States. Almost 3 million in the US do have glaucoma that we know of, and at least half of them don't even know it. They don't have symptoms early on. They can't feel or sense that there is something happening to their vision. They might come into the clinic just asking for a pair of glasses, just a recheck of their prescription. They may have perfect 20/20 vision, but only by careful examination, by incidental findings on exam, do we realize that there is something we may need to pay closer attention to in the future. Anyone can get glaucoma, any race, any age. I've seen infants to elder 90-plus-year-old adults. There are some racial predilections for glaucoma, particularly more highly pigmented individuals, blacks, Hispanics, Mediterraneans like myself. Certain genes have been identified in certain racial groups. I can speak from the Greek perspective that there have been two particular genes identified, GLC1 and GLC13B, which are found in the population of northern Greece. And as an aside, there are quite a few Greek ophthalmologists who happen to also be glaucoma specialists. Family history is very important as well, too. Each time I see a patient, or at least for the first time, I'll ask, do you have a family member, sibling, a parent, anyone who had to be taking drops long term? Not just artificial tears, but actual glaucoma medicines. Age is also important as well, too. As we mature, as we all get older, there is a predisposition to showing some early signs of glaucoma. Similar with macular degeneration, as the population lives longer and longer, we are more prone to see more and more of this as life goes on. Other factors that can cause glaucoma: poorly controlled diabetes, poorly controlled hypertension or blood pressure, previous trauma to an eye, previous cataract surgery. Any kind of surgery to the eye can statistically raise your risk of having glaucoma later down the line. As I mentioned, there are no symptoms early on, but as the disease progresses, there can be progressive vision loss. And once that's gone, cannot be recovered. A representation of what glaucoma might look like from the patient's point of view. On the right here, you can see a slow dimming of the peripheral vision, some desaturation of color and detail as well too in an advanced glaucoma patient. But this is where the basic dilated eye exam, comprehensive eye exam, checking the vision, checking eye pressures, and most importantly, doing a dilation. Dilated exams for many patients can be quite annoying, especially when it's sunny outside like it is today, having to drive home. But it is an essential part of our exam. It allows us to see the entirety of the eye, not just the front of it, but the entirety of the back. And an image here, a diagram shows in form how important it is. With a larger pupil, we can get a larger and more extensive peripheral view of the entirety of the retina, including that most important optic nerve. Glaucoma on an eye exam. I want to briefly show a video brought to you by the NIH. In a dilated eye exam, here's a cartoon, of course, we dilate the eyes, and there you can see we have a nice opening up of the view. Centrally here, you can see the macula, the dead center of our vision, details, color, the This is where macular degeneration can develop. The view is sweeping around the retina, and now our attention is drawn to the main center of action here, the macula, and now looking at the optic nerve. I'll let this run for a moment. This is the optic nerve. In looking for signs of glaucoma, I'm looking at the color, shape, thickness, health of the optic nerve, thinking of it like a donut or a bagel. The smaller the hole, the smaller this cup, the more thickness, the healthier the optic nerve. But as you can see here, with progressive high pressures, that cup, that center of the nerve can slowly atrophy and create a larger cup and a thinning of the natural optic nerve rim. If allowed to progress far enough, this can lead to the vision loss that we are trying to avoid. Okay. Moving on. Glaucoma treatment. Traditionally, we've used medicines in drop form. In the past 3 decades, we've found laser procedures that can also accomplish the same goal in tandem or alone with drops, and traditional surgeries, which are always used as a last resort. How do you protect your vision? Come to the eye doctor at least once every 1 to 2 years for a comprehensive dilated examination. Of course, take good care of yourself. Don't miss your doctor's appointments. Take your medicines. And of course, the government will always tell us wear your protective eyewear when in the workplace. To remember, glaucoma has no symptoms, can result in loss of vision, blindness. Next. Any questions before I proceed with the presentation? Any questions at all? Okay. Now, glaucoma basics. Yes, ma'am, please.
Why is it that dry eye has some of the symptoms of glaucoma, and how do you discern that?
So, dry eye and glaucoma. Dry eye is a common affliction in this part of the country, particularly for patients who are already on glaucoma medicines, glaucoma drops. Glaucoma drops have preservatives and other constituents that can irritate an already dry and irritated eye. Now, symptoms of glaucoma typically do not happen. There's not really pain involved in glaucoma. There's no pain or discomfort. It typically is just a slow regression of the vision itself. But dry eye and glaucoma, that's one of our big challenges as glaucoma specialists, as ophthalmologists, to try to handle the side effects, the potential side effects of drops with a very cold and dry air that particularly happens in this part of the country this time of year. I will speak a little bit more about the drops themselves, but again, glaucoma does not really have symptoms early on. But the treatment of glaucoma, especially for the already dry eye patient, can be a trouble. And it takes a little bit of an art, the art of medicine, to find out what the individual can tolerate best in order to help protect their vision. Yes, sir?
With the pressure increasing with yoga exercise or caffeine perhaps, is that something that early on you think about or later on?
Very rarely do we consider that. I encourage all patients, whether mild to severe glaucomas, to maintain their normal physical routines, including aerobic exercise. Even with yoga poses and the weight lifting, the time involved in lifting something and putting it down, that valsalva, that pressure that builds up towards the head, is so temporary and short in nature that it's not significantly going to affect your optic nerves. The rare exception would be, for instance, the bat. If you were to like to hang upside down by your toes like a bat for 23 hours a day, that might be something different. But in general, we try to, there's little concern. I want the patient to be healthy and active as much as possible. All right, let's begin. Baseline examination. Excuse me, let me do this. And play slideshow. There we go, good. At the baseline examination, when a patient comes in, we do a screening of tests, typically done within the first 2 eye visits, including applanation tonometry, or the measurement of an eye pressure, pachymetry, which is a measurement of the corneal thickness, the front of the eye, gonioscopy, visual field testing, a dilated comprehensive exam, and computerized imaging of the optic nerves, OCT, as well as photographs of the optic nerve. For eye pressure, traditionally, we have the air puff machine. If one goes for a basic eyeglasses examination, a patient goes up to the machine, they put their chin in the rest, and a puff of air blasts their eye. And patients get a little bit nervous about that. It is a quick screen, but often prone to error and inaccuracy, that is. The traditional gold standard treatment or measurement of pressure is applanation, in which we actually physically touch the eye itself, as you can see to the right. This is the gold standard test. It's been available 120 years. The Swiss and Germans back in the early 20th century perfected this technology, which we still use to this day. Of course, touching the eye with that tip, we have to anesthetize the eye, and often you'll see us instill a yellow dye that has anesthetic in it. This allows the examiner to more accurately measure the eye pressures. The average pressure in the population roughly is 10 to 20 millimeters of mercury. Millimeters of mercury is the measurement of the pressure. It's the unit of pressure. And eye pressures higher than 20 can arouse a suspicion for glaucoma. And this will demand us to follow the patient up more closely, including performing some baseline glaucoma testing. However, many glaucoma patients, even those who already have some early vision loss, can still have pressures that have never gone higher than 20. And these are particularly challenging patients because they can often go missed or on any screening examination. The one variable we can control in this disease, what we can do to prevent vision loss, is controlling the eye pressure. We treat glaucoma by lowering the eye pressure, whether by medicines in drop form or pills, laser, or surgical procedures. Pachymetry in Greek, pachis means thickness. We're measuring the thickness of your cornea. The thickness of the front of the eye, the cornea, affects the true measurement of the pressure. For instance, those who hereditarily have a thinner cornea, if we were to measure a pressure of 20 in a thin cornea, that pressure actually is underestimated. In a thinner than average cornea, a pressure of 20 might actually be a pressure of 23 or 24. And conversely, the opposite. For a thicker cornea, greater than 540 microns or micrometers, the eye pressure could be overestimated. In other words, a measurement of 20 at the examination might actually more be close to a pressure of 16 or 17. So this is an essential screening part of our exam. Gonioscopy, another Greek word. Gonio meaning the angle or the approach to the drainage system in the eye. This requires anesthetic drops as well too, but it allows us to visualize how open or closed the angle is. How risky, what is the risk of this patient developing a high pressure in the future? Again, this is all done at the microscope. A cartoon image of what the angle is, and you can see those red arrows, the fluid flowing from the back out to the front of the eye into the drainage system, also known as the trabecular meshwork. The angle houses the trabecular meshwork at the end. And the more narrow the angle, the higher the propensity for an eye pressure rise. So this is what I have to analyze before we continue on with examination. Any questions before I continue? Okay. Everyone has fun with the visual field tests. This is the gold standard test to detect any early peripheral vision loss. Thank goodness nowadays we have machines, automated machines, in which the patient can apply their head into a bowl, within which lights will flash into their peripheral vision. With the help of an examiner, a technician, coaching the patient through this, because it can be frustrating for some patients, Some will get trigger happy, some might fall asleep at the wheel, some are just tired or their necks might hurt. But once a year, I encourage my patients and really push them to try to do as well as they can on this test. It really allows us to detect if we're doing enough, if we're getting the pressure down enough, or are they beginning to lose some bits of vision that we need to be more aggressive with. As you can see on the right is a printout of what a typical visual field test result looks like. Unfortunately, you can see some dark areas on that visual field indicating early peripheral vision loss. As I mentioned, it's the gold standard to detect vision loss. This is an example of a patient over a 12-year span. As you can see on your left, that grayscale representation of the visual field, just a single dark spot, that round dark spot on the left, that is the natural blind spot, which we all have. This patient was being treated with a single drop, but then, for about 3 years, was lost to follow-up, had not come back. And this is what happened. You could see in the middle visual field an early inferior or lower peripheral vision loss beginning. Then the patient came back, we did some treatments, then they disappeared 6 months later and didn't return until many, many years later, had not been taking their drops, and this is what arose many, many years later, where a thickening or a more dense loss of the visual field, and most frighteningly of all is an encroachment, that vision loss encroaching the center of the vision. This could have been easily prevented with more regular follow-up with the doctor, of course taking the drops faithfully, and of course being able to monitor their progress. But this happens typically slowly, and unfortunately there are no symptoms to prompt the patient to say, hey, there's a problem now, I need to come in and see the doctor again, until the damage has already been done. Representation of what a dilated exam looks like. When we dilate the eyes, below here, these two images of a right and a left eye are what a normal optic nerve and normal retina should look like. A little bit zoomed in. To your left is a healthy optic nerve, as I mentioned, the donut or bagel, a healthy nerve with a small cup, a small hole in the center. But to the right, you see, can you see the difference? Can you see that difference? That cup to disc, that cupping is larger. The rim of the optic nerve is thinner. And this, by examination, for instance, I see a 30-year-old yesterday who had a family history, came in for some glasses, but you look at her optic nerve, and it tells me this is someone we may have to pay a little closer attention to. This is a patient whom I might ask to bring back in 3 to 4 months to complete some baseline testing and get the complete picture before deciding when to next see her. And another photograph on the on the left, a normal optic nerve, and on the right, even more severe cupping or atrophy of the optic nerve. In this nerve, this patient would likely have pretty significant peripheral vision loss, perhaps just remaining with a central island of vision. And of course, this is what we're trying to avoid. Also important in our examination, and just in the past 15 to 20 years, has grown the technology of OCT, optical coherence tomography, a computerized imaging of the optic nerve to a resolution of 3 to 4 micrometers, tiny, tiny. The benefit of this technology is it allows us to detect early thinning, early atrophy of the optic nerve that neither I or really any eye doctor can otherwise detect just by the naked eye itself. This imaging often can guide me to say, okay, this patient I may be able to continue monitoring versus, oh, I see here, and you can see the pie charts on the right, areas of yellow and red. Those are flags for me to pay close attention to see, okay, there are segments of this patient's optic nerve that are not as thick, not as healthy as they should be, prompting me to see the patient more frequently and treat accordingly. Yes, sir?
The difference between a disc in a retina OTC?
The patient, you asked about the difference between a retinal OCT and an optic nerve OCT. Same technology, it's same imaging itself. The retina OCT is used to check thickness of macula for patients who have macular degeneration or diabetic retinopathy. Other conditions that affect the central vision, we can use the same machine for both. Same protocols. It's a test that you basically walk into the machine. It takes a half a second to take the image, and it produces nice data for us to use.
So the disc is really looking at the optic nerve?
We're focusing more detailed onto the optic nerve itself. Yes, sir. Yes, sir. It's a reliable, reproducible as well, reproducible way of monitoring the progress of the optic nerve. And if I mentioned, serial testing shows some early thinning or changes. This prompts us to begin some treatment. As I mentioned earlier, not all glaucoma has high eye pressure. There are patients who come in with suspicious-looking optic nerves, but their pressures have always been perfect. They've always been 14 or 15. Their vision's been excellent. They're feeling no problems. They're wondering, why, doc? What's going on here? Why do we need to come back sooner? And this is called normal or low-tension glaucoma. They may have normal pressures. They may have perfectly normal visual fields. But on the computerized imaging, there's some evidence of early atrophy going on. And this means we need to see you a little bit sooner and track your progress. Get some data points over time to determine if this is a process or just a fluke going on. The glaucoma suspect is an actual diagnosis of features suspicious for glaucoma, what I call the cup-to-disc ratio, how large that cupping or the central depression, that central hole of the optic nerve, an eye pressure of 20 or greater, a family history of glaucoma, Black Hispanic race, and ages older than 60. The more risk factors for a glaucoma suspect for an individual patient, the more likely we are to intervene and do something, whether begin drops or laser or other. Yes, sir?
Explain the cup-to-disc ratio. Are you looking at the depth of the cup as to the diameter of the...
In 2 dimensions more so. Yes, the computerized imaging, the OCT can assess how deep the cup is, but on examination, on manual examination at the slit lamp, at the exam, what the cup-to-disc ratio is the percentage of cup to the entirety of the optic nerve. For instance, this optic nerve on the left here, I would call that cup-to-disc ratio a 0.8. So 80% of the optic nerve is that cupping. On the right side of the image, it's a little bit faint, a little bit less. I might call that a 0.7. It's a judgment call, but the key is to remain with your physician regularly. Each physician may call it a little bit differently, but it's a way of eyeballing it and determining, okay, how suspicious this is. Typically 0.6 or above, I'm going to be a little bit more suspicious and more likely to bring the patient sooner. But again, the decimal value is roughly a percentage of the entirety of the optic nerve that is being cupped out. Yes, sir? And of course, there is a monitoring routine. For many of these patients, suspect or not, I'll typically see them every 6 to 12 months. And we'll repeat pressure measurements. We'll do a look of the optic nerve, whether dilated or undilated, and all of the testing we've just mentioned now. So when do we start treatment? Well, as I mentioned, early signs on the OCT, early thinning on the imaging itself, any indications of early peripheral vision loss or a rise in pressures prompts us to begin treatment. And traditionally, in glaucoma, we've used medicines in drop form. In solution, these medicines applied to the eye once or more a day can help lower pressures to a safe level. It's been the traditional method of treatment, and there are a multitude of drops on the market, both generic and brand name. Yes, sir?
How does it do that?
So the medicines, there are certain classes of medicines that have been used the medicines actually directly absorb onto the front of the eye, the conjunctiva and the cornea. The medicines are formulated to penetrate so. We prefer topical medicines as opposed to systemic medicines for the obvious concerns about systemic side effects. We try to mitigate any effects to the rest of the body, though it's not uncommon for some patients to be sensitive. Certain topical glaucoma drops can affect blood pressure, and can affect other parts of their well-being and their health, and so as a physician, I have to pay attention to the entirety of their medical drug list, their conditions, whether they've recently been on steroid treatments, and various other conditions. So, yes, sir.
So the liquid opens up the draining in the mesh.
Some drops will stretch open up the drainage system. The drainage system has some musculature to it and has been known some medicines can stretch or get those muscles to contract or relax, allowing drainage of fluid out of the eye. Other drops will actually allow drainage of or will reduce the production of aqueous, reduce the production of fluid in the eye, hence lowering the pressure. And oftentimes, for the more severe patient, we'll use multiple drops with different mechanisms of action to achieve that proper lowering of pressure.
And you use the term laser a couple of different times.
Yes.
How do you approach that with the laser?
We're getting to it.
Great.
You bet. Yes, as I mentioned, oftentimes more than one drop may be needed to adequately lower eye pressure. And upon starting a drop, we hand the patient a sample medicine to take home. We'll give them 2, 3, 4 weeks to try it out, to get into the routine, see how they tolerate, and then we'll have them return to recheck their pressures. And if satisfactorily lowered, we can then prescribe the medicine. I typically like generics, like brand names. My goal is to try to enhance compliance and consistency with the routine, because medicines are expensive enough these days. I feel that in the real world, generics and brand names are both equally effective, but individually work with each patient and see what their preferences are. There's a maintaining of a yearly testing schedule. Just because we start to drop doesn't mean that I'm going to see you back in a year. Yes, ma'am.
I just want to ask about no pressure or normal pressure glaucoma.
Yes, ma'am.
If pressure isn't the problem, what are the drops doing, and why is the glaucoma occurring?
So normal tension or low pressure glaucoma is not all pressure related issue. In other words, I will still, even if a patient comes in with a pressure of 14 or 15 and they show some visual field loss, my goal will then be to try to drop that pressure down to 10, for instance, 30 to 40% lowering. Science is still emerging as to what causes atrophy of the optic nerve. What we're learning now is it's not all about pressure. We also have to consider the patient's vascular state, their cardiovascular health, how well blood is flowing to the eyes, to the optic nerves, how it's happening during the day, how well they're oxygenating and getting blood to those vital organs at nighttime. I'll often ask about whether they have breathing problems, snoring, if they need to be on a CPAP machine to get better oxygen overnight. We're learning now that there are factors like that, how well we oxygenate. We're learning about certain chemical mediators, chemicals in the blood that are becoming more associated with optic nerve loss. This is still evolving science. We're still kind of working in the medieval ages as far as treating glaucoma just with pressure, but this is what makes low pressure or normal tension glaucoma more difficult to treat. We have less control of the condition, and that's where I ask the patient to be very faithful with their primary care, making sure their blood pressure is addressed, their cholesterol, and the basics that we require to live a healthy life. Any questions before I begin? Continue? Okay. All right. My job is to ensure that you can take your drops faithfully. My job is to educate and motivate you to take them. It's frustrating for some. Some patients just don't want to be bothered with that. And our goal here is to encourage and motivate you. Each patient is different. And some patients I'll have to be a little bit spend a little bit more time with them, hand holding them, and others just know what to do. And that's okay. That's okay. My goal here, our goal here, is to develop rapport with you and build your trust in us. And that takes time. You mentioned the laser. As an alternative to beginning drops, this is selective laser trabeculoplasty, a procedure that we perform regularly here at Cleveland Eye Clinic. A procedure that has been in existence almost 20 years now. It takes 2 minutes to perform. For patients in whom they may not want to begin drops, be burdened with having to start drops and take it lifelong, I can offer this procedure. Alternatively, for patients who are already on drops and their eye pressures have not been adequately controlled, this is a nice adjunct or additional treatment to try to get their pressures a little bit lower so we all feel, safer about their condition. Yes, sir.
Why doesn't it work after a couple times?
So, the laser itself is a cold laser. It is not a destructive, like a thermal laser. It is a laser that works at the molecular level of the angle, the trabecular meshwork. After the second or third performance of a laser, the macrophages within the trabecular meshwork no longer respond to that stimulus. We have found over time, we don't exactly know the mechanism as to why, though I have had some patients who have had 3 or 4 lasers done in a 20-year period, successfully have kept their eye pressures down and have not needed drops. Conversely, I've had patients who came in and said, "Doc, I don't want to start drops yet. Let me try this laser first." And it may not touch the eye at all. The difficult part is we have no way of predicting, just by looking at the patient, how well each individual will react to the laser itself. But my job is to try to encourage them and alleviate any fears about the word laser, as some people may recoil in fear about having something, shot into their eyes. It is a simple, painless procedure. The patient can drive themselves to the appointment, drive themselves home, go about their days, with minimal side effects other than feeling perhaps a little scratchiness of the eye that day.
How does the laser work that it doesn't damage like the cornea? Is it where beams converge, or?
With the help of that gonio lens, that contact lens, and the skill of the surgeon has to direct it. In any procedure we do, especially in ophthalmology where things are tiny at the micron level, it takes a steady hand and practice, and you have to aim that thing right. It can be done, but the beam itself is 400 microns, and there has to be careful aiming. You always have to get a good view of it. Yes?
But it passes through the cornea and hits, or?
Yes, it transmits right through the cornea. It does not, yes. We have two aiming beams of the microscope, and where the beams converge is where the energy is focused. Yes, sir. So, yes, it will not damage anything in its path until it has reached its target. I don't have any videos for you today to show you, but that's basically it. And what this laser is doing, as you can see in this cartoon, is creating these spots. They're not really drilling of holes as much as changing the architecture of the drainage, the trabecular meshwork system.
One other question, and I may not be pronouncing this right. Iridotomy?
Iridotomy.
My brother just had that. What is that?
Iridotomy is a different laser application where we try to open up the angle, not the trabecular meshwork, but open up the angle between the cornea and the iris. For patients who have a narrow angle, creating a hole through the iris allows flow and an opening up of that angle system. We don't do that as much nowadays, but plenty of patients still do come in. Again, a very quick and simple procedure, usually half a minute, and they can go about their day thereafter. Another cartoon representation. And on the bottom right here, you see the aiming beam we were speaking of. That red dot is focused right on where the laser needs to be applied. And typically, I'll apply 100 spots around the 360 degrees of the angle system. Some other new stuff on the market, the injectable implant. I call this the holy grail of glaucoma treatment because for many patients, if we can limit the number of drops they need to take, this is a great achievement. is still in development. We're still figuring this out. The FDA has still put some limitations on how often we can inject this implant. But a pellet, a medicine that can be injected into the front of the eye at the microscope in the office with a little anesthetic on the eye. This is injected into the eye, and this pellet slowly releases medicine over 9 to 12 months. In preliminary studies, we've seen some patients achieve good pressure control for almost 2 years. In some patients, we don't see as vigorous of a response. Again, these are emerging technologies, and I'm hopeful that in the next decade, we can see more medicines impregnated in these pellets to try to limit the burden of instilling drops every day. Minimally invasive glaucoma surgery, or MIGS. These are small incision surgeries that I perform. They're short, with a short recovery, often less than cataract surgery. Very safe, well tolerated, and it's a nice next step, a little bit more aggressive step in lowering pressure without having to do a full-on surgery. I will go over these with you, including stents, lasers like endocyclophotocoagulation, canaloplasty, goniotomy, and tubes. Here is an array of stents that can be used to lower eye pressure. What we're doing with a stent is it is acting as a bypass. One's drainage system, their angle, their trabecular meshwork is no longer open. In order for the fluid to exit, we put a snorkel or a tube or some conduit bypass to shunt fluid out of the eye. To your right, you see the Zengel stent, the Hydra stent, iStent, Inject, iStent. The CyPass is no longer on the market. It was discontinued in 2019. One of my favorite implants, the Hydrus microstent. This is a piece of nickel titanium metal, flexible, tiny, as you can see it compared to a dime. The same material that we use in heart stents when we do angioplasties in patients who had myocardial infarction. These fit into the drainage system in the eye. They're tiny, can never be seen, you'll never feel it, and it takes 2 minutes to perform. Right now, the FDA only approves this implant to be injected, to be installed during cataract surgery. We're hoping in the next 6 to 12 months to hear from the FDA regarding standalone use for these stents. The lovely thing about these stents is they can really do a nice number. They can lower the pressure nicely, and the healing time is negligible. It's basically a week. Another technology is the iStent Inject. Look how tiny these little snorkels are on a penny, basically close to the nose of Abe Lincoln. These are injected right into the meshwork, basically as a snorkel or as a way for the fluid to exit the eye. You can see that on gonioscopy on that photograph there, those little snorkels there. Endocyclophotocoagulation, long word for lasering of the ciliary body. Just a brief review of anatomy. You can see those striated or plicated organs, the brown material just underneath the iris. The laser is being applied to the ciliary body. That is the portion of the eye that creates the fluid. What we try to do with this laser is shrink those production centers, shrink that body. We don't burn it, we don't destroy it, but by shrinking it, we can reduce the production of fluid in the eye, reduce the flow. For some patients, this can be very helpful. This can be performed both standalone and in conjunction with cataract surgery. Cyclophotocoagulation, a similar concept where we shrink or treat the ciliary body with external, without having to go into the eye. That's another technology we can use both in the office or in the operating room. Canaloplasty is something I perform regularly. At the time of cataract surgery, with fine instruments and a catheter, I can slide that catheter and stent open the drainage system for 360 degrees. This can be effective in lowering pressure another 10 to 20%. Is a quick procedure with minimal recovery as well too. Goniotomy, the same deal. Instead of cannulating or opening up the drainage system, we actually can strip it out completely. For patients who have poor pressure control, who are on many drops and are not quite well lowered yet, their eye pressures are not safe enough, this is yet another procedure I can easily do. It takes 2 to 3 minutes in the operating room with a very short recovery. And tubes, yet another form of bypass, a procedure that takes 5 to 10 minutes. Again, another way of shunting the fluid. I'm not going to go into major surgeries today, but I wanted to show you some of the more conservative means of treatment, some of the more emerging technologies that we're using here at Cleveland Eye Clinic. And this is a great practice where we have innovators here. We have docs here who are trying the latest and greatest. We have clinical trials ongoing with different manufacturers to find the best for our patients. Our goal here is to get the pressures down in the most safe way possible, limiting surgical time, limiting recovery time, and getting you back to your life routines. And I think that's it for today, but I will take questions. Yes, sir.
How do you determine, since there's so many different types of surgeries, from tube shunts to eye stents to canaloplasty to on and on, how do you determine which one is best for a patient? I tend to be more conservative compared to some surgeons in that I want whatever it takes to get the eye pressure down with the minimal side effects. Now, drops and laser have been the traditional method of treatment. Now, depending on how low a pressure has to be. If a patient is already on a couple medicines, their pressures are still in the low 20s, then a procedure like a tube, one of those mini tubes or a stent, may be just enough to get 6 or 7 points lowering of pressure. It depends on the degree. It depends on the severity of the patient, how much vision the patient has already lost. How much are we really going to achieve by doing a minimally invasive procedure if that patient really needs to get their pressure way down further? Many of these procedures, they're nice, they can adequately lower the pressure, but for a more severe patient, I may need to be more aggressive. So if the pressure's up, let's say, above 30, 35, it's a completely different surgery than it was if it was down at...
Not necessarily, because with many of these minimally invasive procedures, we could easily get a pressure lowering of 10 to 15 points. But as I said, some patients, especially those who've always had normal pressures, they may not need just to get down under 20, but need to get down to 10 to 12 range. And that's where trabeculectomy and other more invasive procedures that I can perform, that's the place for those. So it's a feel. This is part of the art of medicine. There really is no formula. I'm never ever following a strict flow chart when it comes to these treatments because each patient is different. Your priorities might be different than the next person, and some patient just wants to be left alone and just get by, and some patients want to be more aggressive. And again, that decision is made between me and the patient together. Because
a little bit of reading I've done, they always refer to that trabeculectomy as the gold standard.
It is. In a pinch, as a last-ditch effort, when other technologies have failed, or an eye that's very sick or that has had lots of other procedures done to it, whether retinal detachments, trauma, that remains the end-stage treatment, which we still perform, but I try to avoid them a lot nowadays simply because of potential side effects. The healing time often can take a month or 2 or more, and it requires a lot more post-operative care. It requires more effort by the patient to come back regularly to attend to the trabeculectomy and make sure that things are flowing properly. It takes a lot more attention. These newer procedures are not set and forget, but allow a little bit more flexibility for our routine and schedule. Yeah. Any questions? Anything else? Yes, ma'am.
So assuming the patient is compliant following the treatment plan and the visits, is it a natural progression that happens that through time you anticipate there to be more deterioration and the increase in drops, or have to evaluate another intervention?
Invariably, yes. But that's not the majority. The vast majority of patients, young or old, assuming that they can tolerate and are remaining faithful with their treatment, they can preserve their vision for a lifetime. It all requires regular, routine follow-up, daily commitment to the drops themselves. There are, of course, always exceptions, and oftentimes other concurrent medical conditions can affect our progress. Especially as we all age, things happen. And it's my job to work around those, especially if a patient's blood sugars are out of control, they're struggling with that. If they happen to have autoimmune conditions or on steroid medicines. Steroids, I brought up steroids again. Steroids have been known, when taken, steroids, whether taken by mouth like prednisone or inhaled for breathing, for asthma, or injected into your joints for arthritis, or even some steroid over-the-counter cream. For some patients, that can actually raise eye pressure. And I don't tell the patient right away. I don't tell them to stop the steroids. I tell them, treat your condition. Your doctor wants you to put this thing for your rash or get injections for your joints. I tell them to continue with their treatment, but that prompts me to change our treatment, to add a second drop, or perhaps offer a laser to try to bolster and get us over that hump, with the assumption, of course, that you're not going to be on that steroid long term, of course. Yes? Hello?
I got a question from one of our online viewers here. They're asking, why are some patients who have stents inserted able to go off drops while others cannot?
That's an excellent question. For some patients, those stents, depending on the individual and the individual eye itself, those stents can be effective enough to get their pressures down and have them stay down. In some patients, it may not adequately do it enough. It is such a safe and well-tolerated and simple procedure for all patients that I perform them regularly. But again, it is almost impossible to predict how well each individual will respond. I have many patients whom I'll apply a stent at the time of cataract surgery, and for many of them, we can eliminate a drop, but we may not be able to eliminate all of their drops. For safety, in the interest of preserving their vision, we're going to continue treatment depending on how well those pressures get controlled post-surgery.
How do cataracts play into this?
So, cataracts typically are independent of glaucoma progression. I will tell patients they'll come in because their vision is becoming terrible, they're having trouble with nighttime driving, or they're just not seeing as well as they used to. What I tell patients about cataracts is, cataracts can be easily removed. We can get you back to normal, seeing like you were 20 years old again. Glaucoma, however, the vision loss cannot be recovered. Oftentimes, many of my patients who have glaucoma are in the age group 50 and above, that time in which cataracts begin to emerge, in time in which patients notice their vision changing or having trouble with driving or doing small tasks. And it's a great opportunity at the time of taking out their cataracts to improve their vision, especially that glaucoma patient. At the time of cataract surgery, to offer a stent procedure can be really, really big for that patient, and perhaps, of course, eliminate a drop or perhaps the need for drops in general. Anything else, folks? Well, I thank you very much for your attention. Thank you for coming in and celebrating with us here today. And if there are no other questions, we're going to have some refreshments and share our clinic and show you around here today. Okay? Thank you. Thanks.